So today is the second day of the infectious disease round, and yesterday what we ran in the previous video, that the first principle of infectious disease is that you should come to know about the source before changing the antibiotics. If you want to change the antibiotics, then you should see first what is the source and why this antibiotic should be changed. So the second day is about the major pillar of this infectious disease is that choosing the right specimen, it is more important than ordering many tests. So it is called as diagnostic stewardship, that you should take care of the specimen. Don't just blindly send the many samples as many you want. No. So we clinicians, they send random investigations like anything what they want, but the strong people, they should know that what sample to be sent and when to send. It is also very important the time of sending the sample. Every time you cannot get the same organism. So when to send, from where to send, how much quantity, because quantity is also very important. So before or after antibiotics, and how to interpret it. So these are the important things which every infectious disease person should know. So coming to the day 2 of this training, the important part is diagnostic approach and the specimen strategy. So that is very important. So for the morning pre-round on the second day, there is a case. Case is 58-year-old male on ventilator, develops fever, increased secretion, rising oxygen requirement, leukocytosis. And fever, increased secretion, rising oxygen requirement, and leukocytosis. So you can see here that how these symptoms they are, you are going to correlate with the diagnosis. So ventilator day is day 6th. So today is the 6th ventilator day, and this shows that the person is developing VAP. Current antibiotics is piperacillin tazobactam. That person is receiving this drug, which you should check when you are at the round. You should see what happened to the patient, what is the present status of the patient, whether the patient is improving or not, what antibiotic was given to him. So if the person is not improving, even then you have to change. If the person is improving, then you can de-escalate. Then you should see the chest x-ray, new infiltrates are there. So I think patient is not improving. Now your question may be, what syndrome are you thinking of? So I have already told you that it is VAP, that is ventilator associated pneumonia. But stop. ID fellows, they never jump immediately. You must first ask whether it is a true infection, whether any pulmonary edema is there, ARDS is there, atelectasis is present or not, aspiration is done or not, pulmonary hemorrhage, if any. So these are the things, and this we will see why they have asked this. So teaching point here is infectious disease diagnosis is syndrome. So you should see microbiology, radiology, and clinical correlation. Never culture treat blindly. So you should see all the things, culture as well as radiology as well as clinical correlation, anything else if you want to. Then which respiratory sample will you send in this case? So the possible options are endotracheal aspirate, BAL you can send, mini BAL, sputum, blood culture. So you should know the difference between these respiratory samples and why they are sent in the respiratory infection. What is the difference between these, how they are collected, and how you should how and when you should collect them, why not every time BAL, which one is better than the other, and what is sputum, what is BAL, how sputum is collected, how BAL is collected, and in which case which one should be preferred. So here these things you should know. Now think which is feasible, which is contaminated, which gives meaningful results. So out of these samples they are saying which is possible, मतलब feasible कौन सा है, how can you take it easily, then which is contaminated, so you want pure growth, so many are contaminated. Then which gives meaningful results, so if there would be contamination, you won't be able to you know easily diagnose the disease. So but even then which is going to give the meaningful result, maybe ki some sample is not good for collection here. So the coming to the respiratory samples, what you should learn, that sputum useful in non-ventilated patient. If the patient is non-ventilated, then go for sputum. But poor quality sputum is dangerous. It is very difficult for to collect the good quality specimen. You have to ask the person to collect to cough from the very deep inside, and then you collect the good sputum. So always assess with how many epithelial cells are there in the sputum, how many pus cells are there. So pus cells should be more, epithelial should be less. There are how what is the chance of contamination, because it will come out through your oral mouth, so oral cavity, and there microorganisms are present, so it may get contaminated by that. Now the good sputum is when there are many neutrophils and few epithelial cells. So endotracheal aspirate. Coming to the endotracheal aspirate. So common ICU sample. Advantage is easy, rapid, less invasive, because already this tube is there, and if you are going to collect it with that, I think no problem to the patient. It is less invasive. So disadvantage is in this colonization is more common in the endotracheal aspirate. Then BAL is bronchoalveolar lavage, and it is better lower respiratory sampling for lower respiratory tract. It is better. It is useful in atypical infection, immunocompromised patient, fungal infection, and non-resolving pneumonia. But it is invasive, it is costly, it requires expertise. So the deeper the sample, the better the interpretation. So the deeper you go, you can get better sample. If you are upper side of the respiratory tract, chances of contamination is more. So invasiveness and patient stability matter, because every time you don't want to perform for the collection of sample invade the patient. So should culture be sent after antibiotic escalation? Best answer, ideally before antibiotic change it should be sent. Then why? Because antibiotics they reduce the culture yield, so it is okay if that culture is if that antibiotic is not working, it is fine, then you may get that organism in your sample. Then critical in id principle is, if the sample is bad, you will you will go for bad microbiology, and then again you will go for bad antibiotics. So it is very important to have a very good sample. So this cause over treatment, it may cause resistance of the antibiotics, it may cause unnecessary evaluation. Now comes the blood culture. So now the patient has spikes of fever. What should you do? So correct blood culture technique should be performed. Now the important point here is before blood culture collection, that before antibiotics it should be done. Most of the time for culture it should be before antibiotics. 2 sets minimum. Now what is set, that you should know. 2 sets minimum. Separate venipuncture sites. Venipuncture sites should be separate, and volume should be adequate. This is very important point for the blood collection. So most important factor here is that blood culture yield is more if the blood volume is more. Then what questions can be asked? Why are blood cultures falsely negative? Think deeply. For this reason we know, if the prior antibiotics has been given to that person, if the person is has given low volume of blood, if there is intermittent bacteria and you have not taken the blood at different times, then fastidious organisms will not grow. Fungal infection if would be there and you have not gone for the fungal culture, no growth will be there. And if the timing is wrong, so these are the important points which you should remember. Now, for the day 2, the major teaching is this was all the pre round. Now, colonization versus infection you must know, because every time you are saying in each sample you should know that it is a colonizer or it is a true pathogen. So, ventilated patients often grow Pseudomonas aeruginosa, Acinetobacter baumannii, and Candida albicans. This is for the ventilated patient in the ICU. So, does every isolate require treatment? No. Especially Candida in the respiratory secretion often indicates colonization. So, not for the Candida. Now, culture report must fit the patient. So, never ask what organism grew. What you should ask, does this organism explain the syndrome? If this organism can cause it, if it can cause it, then it is fine. If cannot, then just avoid. Now, for in the second time after the break, you will see that how you should work up for the fever. So suppose the patient is having fever, then and you are unable to find out the source, do not order the random test, then approach systematically. If the person is having cough, infiltrate, if oxygen levels are going up and down, then you should go to test the lungs. If there is catheter, if the person is complaining of dysuria, then you should go to check the send the urine and look for urinary infection. Surgery, tenderness, drain, then go for abdomen. If there is any headache, meningism, then go for CNS. That is, you have to send the CSF sample. If any central line is there, prosthesis is there, any devices are there, then you should send that thing or the sample. Cellulitis or wound, then you should check for skin. So what biomarkers can be sent? Okay, so that was the directly sample, but your body also react for if there is an infection, or then you should check for CRP, which is useful to see the inflammation trend and monitoring response. So this can be sent. Limitation is that it is non-specific, you don't know where it is, where the inflammation is happening in the which organ. So procalcitonin, this shows the favor of bacterial infection. Stewardship, antibiotic discontinuation can be done on the basis of this, but it is not very perfect. Now, important stewardship principle is do not treat isolated CRP rise. If there is isolated CRP rise, then don't treat, because you never know whether it is if only procalcitonin is there, if only leukocytosis is there, then it is not very specific. So all should be there, many other things should be there, then only you should go for antibiotics. Now, the senior bedside exercises that if the patient is afebrile, stable, improved clinically, but CRP is still elevated, then question is continue. Should we continue meropenem longer? Not necessarily. Clinical improvement matters most. Okay. So, what homework can be given to you? For every sample you have sent, what you should see, why was that sample sent? Always think, if you are seeing the file of that patient in the morning, then you should look for it, why that sample was sent. Does the patient truly have infection, or it is just a contamination? What is the best sample type, that you should know as a microbiologist, as an infectious disease fellow, as a medicine person. Possible contaminant is there or not? If, how will the result change the management? If you get the result, then whether this management can be changed or not, because you are not there just to see the file. If you have seen something, then try to change the antibiotic. This is the good training. Then you should what you should read, you should read how the web diagnosis is done. That is very important. How can you say that it is VAP? It is ventilator associated pneumonia only. Then what is, how will you interpret blood culture? That is also very important. That interpretation of blood culture. How you see whether it is colonization and infection, very very important point. Then proper specimen collection methods, everyone should know about that. Then the biomarkers in sepsis, it is also very important. So before leaving you should know that which is what, no culture sent or wrong culture interpretation. So here the answer is not if you have sent the culture and you are reporting it or interpreting it wrong, because it leads to unnecessary antibiotics resistant and patient harm. So the next day we are going to read about the antimicrobial pharmacology for infectious disease person. So it is the real art of choosing antibiotics intelligently. So this we will go for the third day.